The next one is a 20-year-old woman with a skin-colored wrist nodule, present for several years, and it's attached to the tendon sheath on imaging studies. No history of malignancy. So 20, a young patient. Now, that's a perfect section, right? I mean, like a couple folds and a little scratch here. So it happens if you don't protect your unstained slides, little bits get scratched off. But overall, it's a perfect example here. So right down here, this dense band of pink, let's look at that before we look at the tumor. See how wavy that is? Wavy is not usually nerve. Everyone teaches nerve, wavy. Nerves are like gentle waves, maybe, slow and gentle. But when it's like this, you know ramen noodles or instant noodles? The little package of dry noodles that you take out when you're in college and you're poor and you can't eat. I don't know, at least in America we have them. I don't know, maybe not in France.
We do have them.
You have them? What do you call, comment tu dis? Noodle. They're wavy, right? Really wavy when they're dried. And then you add the hot water, and then they get soft. So one of my fellows, Dr. Ed Fulton, really awesome fellow of mine in the past, trainee in dermatopathology, he said, you know, it looks like ramen noodles in the package, how wavy. When it's that wavy, it's usually not nerve. It's usually collagen, dense, regular connective tissue. And that type of tissue encompasses tendon, ligament, fascia, and a lot of things that are fibroblastic lesions that have a background of collagen. What happens is during processing, the tissue shrinks up. And in the fibers that are normally stretched out, they become very, very wavy. So the only reason I belabor this point is that I have encountered not just trainees, but practicing pathologists many times that have struggled to identify that this is not nerve. This is fascia or tendon sheath, dense, regular connective tissue. It can make a very big difference. For the example here, the reason we need to know is that we know that this tumor is down deep enough that it's sitting on the tendon sheath or the fascia and directly adherent to it, attached to the collagen of the tendon sheath. Now, basic histology is always so important. Even now, all the time, one little tiny finding of histology sometimes will make a difference between recognizing that something's not a little bit of melanoma in a lymph node. So I really think you can never spend enough time learning all the subtleties of basic morphology for normal histologic structures. So here, this tumor is a nodule, kind of multinodular. It's very pale from low power. And as we go closer, you can see a lot of the cells truly have clear cytoplasm. All right? In other areas, the cytoplasm is not truly clear, but kind of pale, like here. Kind of pale gray or pale eosinophilic. So it can run a range as far as how clear the cytoplasm is. I think the most classic areas are down here, where the cells are arranged in, again, these kind of nest/fascicle overlap. Okay. They're these, if you cut them longitudinally, they look like long fascicles of plump spindle cells, joufflus, right? Oh, sorry. If you cut them in cross-section, they look more like nests. So it is a matter of three-dimensionally if it's cut long or across. The cells are relatively uniform. Their nuclei are oval and all look like each other, okay? That is a general feature of most translocation-associated neoplasms, particularly in soft tissue pathology. If there is a balanced rearrangement or a gene fusion, usually the tumor will have nuclei that all look alike because they all have the same molecular event that's driving the tumor. Pleomorphism oftentimes is a marker of underlying chromosomal instability or aneuploidy, random chromosomal gains and losses. This is not a perfect rule, but it works pretty well because if you think about all of the translocation sarcomas, synovial sarcoma, Ewing sarcoma, clear cell sarcoma, which is what we have here, And more. They may have mitoses or necrosis, but you don't see pleomorphism usually. Now this tumor, when it recurs or metastasizes, can sometimes get pleomorphic, but usually it does not. And it's a really great rule, solitary fibrous tumor, translocation associated. It's a really great pearl that one of my mentors, Dr. Mark Edgar, taught to me. And he taught me a lot of really great visual tricks and tips in soft tissue pathology that I now pass on to everyone whenever I speak. So the cells are uniform. They do tend to have prominent nucleoli. See the nucleolus there? I'll show you a better area in a minute. Oh, there. Nice nucleolus. Almost that cherry red nucleolus, like the nucleolus of a melanoma, a little bit. The other thing is that in between the nests there is dense collagen, dense pink collagen, dividing these nests or fascicles like this, okay? So these features are characteristically seen in clear cell sarcoma, which has also been called in the past, much to the confusion of many, melanoma of soft parts. We now know these are not melanoma in the traditional sense. They are separate and distinct. And this was first described, or at least the landmark paper describing them was by, I kind of think as my academic grand-père, Franz Enzinger. He trained Sharon Weiss. Sharon Weiss trained me, so he's like my grandfather. He would probably not, I never met him, unfortunately. He died before I was a pathologist, but he, not only this, but he described many of the main entities in soft tissue pathology, really an amazing legend. And it's really great to be able to see these tumors that he characterized in the 1970s and 80s with no molecular or anything, just morphology. Those days, wow, amazing. So that pattern right there is what should make you think of clear cell sarcoma. So a few things. One other thing that's, let me see if I can find it. I should. There's another feature you often find in clear cell sarcoma. Oh, look at the nucleoli there. Very big. And look, the nuclei look round, not oval, because again, it depends if you cut them long or cut them across. The nuclei look different, whether they're elongated or round, right? So, oh, sorry, I don't know why these keep, okay. So that is a good, and then in here, there should be a multinucleated giant cell. I thought I had it. It's right. I've looked at this slide enough times. I should have it memorized, but I get lost. Oh, come on. Do second. We have time. Okay, good. It is embarrassing. I should have. Oh, maybe I did take a picture. Hold on. Ah. That is not a Teuton cell. That is not a histiocyte. It is a tumor giant cell. The nuclei here look the same as all the other nuclei. They are just fused together to make a ring-shaped, kind of halo-like multinucleated giant cell. It's a common feature in clear cell sarcoma. So these tumors, the reason the name melanoma of soft parts or of soft tissue came about is that they do have some similar cytology as melanoma, the big nucleoli. They have a very similar immunophenotype. They stain with S100 and SOX10 and MART1 and HMB45. And I just learned today from Arnaud that they are positive for NTRK, right? The pan-TRK marker, which is cool, and I didn't know, and I'm going to have to try that out in my lab next time I see one. Oh, whoops. That's not a slide, that's a PowerPoint. Okay. There. So when they have classic morphology like this, great, clear cell sarcoma. You see it, you've done immunostains, it stains like melanoma, and then you recognize by the morphology, this must be clear cell sarcoma, and you do FISH or RT-PCR to show the fusion, which is EWSR1, the Ewing's gene, with ATF1 in most cases, and there is a rare variant fusion also. The problem is that if it doesn't have classic features, if it looks like maybe this, well, then you might struggle. Because when I look at a picture of that, I don't instantly think clear cell sarcoma. I would scratch my head and think of a variety of different things. I mean, there are areas here that vaguely remind me of the CRTC, vaguely. Arnaud's probably shaking his head like, no, surely not. But I mean, I don't know, I might think of melanoma. I mean, it's pretty solid. It's not truly clear. It's kind of gray cytoplasm. Yeah, there are some nucleoli, but they don't instantly give me the classic feeling of a clear cell sarcoma. So one thing I recommend is if you had say you had a nodule of melanoma in the deep dermis or subcutis, if you see a nodule of melanoma down deep, that is metastasis until proven otherwise, right? When we see a nodule that's deep dermis or subcutis, that is the way that metastatic melanoma presents. So if I see something that I think is a nodule of melanoma that looks like maybe it'd be a metastasis and it's on the extremity of a young person who has no history of melanoma, well, is it possible? Yes. Melanoma we see present as metastasis with no known primary. On a regular basis, I've seen that. But in a young person on the extremity, that would be rare, okay? So in those cases, I stop and think, could it be clear cell sarcoma? And if I have any doubt, then I do the molecular, because it probably does make some difference for treatment. Say you want to excise these with negative margins, and if it's a metastatic melanoma, usually they will still excise it, but the margin status is not quite as important because it's already stage 3 or stage 4. The other difference now is that in the age of targeted therapies and checkpoint inhibitor drugs, which are very expensive, at least in the United States, and they're drugs that come with a significant potential side effect profile. The potential maybe to cure or turn metastatic melanoma sometimes into a chronic disease, or maybe even cure it, but at the risk of very severe side effects. And I had a relative actually who unfortunately died from metastatic melanoma and took checkpoint inhibitors and really had a lot of side effects, really bad ones from it. So they're amazing, miraculous drugs, but they also at the same time, when you unhook the immune system and let it go unrestrained, it comes with bad side effects. My understanding is that people have tried checkpoint inhibitors, some with clear cell sarcoma, but I don't know if there's been proven success because these are very rare. I only see these maybe once every 2 years or so. Very, very rare tumors. But I always try to think of them if I'm thinking of a metastatic melanoma, particularly in the extremity of a young person with no history, okay? So it's good to know about. You can test for it with molecular. And unfortunately, the 5-year survival is pretty decent. But if you follow patients 10, 15 years or beyond, the prognosis becomes much, much worse. They tend to recur, metastasize to regional lymph nodes, and eventually have distant metastases, which is very unfortunate. So, and they often affect young people, young adults. So it makes it even more tragic. Terrible disease, but one that's good to know about. And I think this is, to me, a very characteristic example of clear cell sarcoma.